I got the message. Okay. Well, good morning to all of you. And as I just said, to those of you that are just arriving, Joe Gallo will normally do these introductions, but today he can't get in. So it looks like I'm going to have to wing it. And so I'll do that. And Joe, you always do such a great job, but I'll try to rise to your level. By the way, these with this AS101, we pre-record these with PCRI, and so we'll have some recorded interviews. Excellent. And then I've invited Mike Glody, and I'll do an introduction for Mike later on. Mike is on our advisory board and extremely knowledgeable he's a urologist and knowledgeable in prostate cancer and oncology as well. But let me introduce him later. And again, thank you, Mike, for coming. We are we do not, this coalition, ASPI, does not offer medical advice. We offer support. We offer a place, a safe place for you to exchange information, to learn information, but we do not offer medical advice, and you should go to your urologist to receive the medical guidance that you need. You should, for this program, actually right now, you should mute yourself and also close your video, because that way you won't interfere with the data capabilities. So we're going to have the video, and then we'll have Mike at the end, and Mike will talk a little bit about genetics and genomics, and he'll field the questions, and we'll kind of back him up on that. And if you have questions, you can put them in the chat box, or you can unmute yourself. As long we don't have the depth to get into the details of anybody's in particular situation, but if you have a focused question and you want to just unmute yourself and ask that question in person, you can do that as well. Either way is fine. And actually, Mike, I think we'll try to support you in monitoring the chat box. Hopefully people will choose to unmute themselves, and then you can just talk to them directly, but we'll see how that works. Bill, am I missing anything that Joe usually says that you can think of?
No, I think you've covered it pretty well. Okay,
thank you. And so do you want to just, I'm going to introduce Phil Siegel, and Phil Siegel is part of the coalition, and he'll speak of the coalition, and he's a member of the Canadian Cancer Group. So let's roll it.
More than a year ago, some of us involved in active surveillance support met to discuss programming for 2022. The idea was to try and avoid program duplication through cooperation among support groups. We all agreed that we weren't connecting as much as we should with newly diagnosed men, or with men in the gray zone, PSAs of 4 to 10, who had not yet been diagnosed. We thought it would be a good idea to develop a series of videos which cover the basics for men and their partners who may be anxious or worried about what was happening to them, with no support immediately available. The videos would be a catch-all group of webinars that would answer the many questions a recently diagnosed man might have, all in one place without having to scour the internet. A working group called the Active Surveillance Coalition was formed to develop this series of programs under the name Active Surveillance 101, an introduction or a basic course in active surveillance. The vision was to have real patients and their partners simulate visits with top experts in the field and cover essential questions. Today's video is with Justin Lawrence of Sunnybrook Hospital in Toronto, Canada. Justin is a certified genetic counselor through the American Board of Genetic Counseling. He practices clinically out of Sunnybrook Odette Cancer Center in Toronto in their cancer genetics and high-risk program. He is also the lead of the Male Oncology Research and Education Program, a registry for men with hereditary cancer, as well as a consultant on the well-advertised PROMISE study. His current academic interests are in hereditary cancer, with a focus on male breast cancer and prostate cancer genetics. The video also features Larry and Nancy White, a couple from New Mexico who have been through this themselves and are our model team. Our programs deliberately avoid the PowerPoint slides usually shown in these type of webinars in order to replicate as much as possible what a real counseling visit is like. The Active Surveillance Coalition includes Active Surveillance Patients International, ASPI, the Active Surveillance Virtual Group from ANCAN, Prostate Cancer Support Canada's nationwide Active Surveillance Virtual Support Group, Prostate Cancer Research Institute, PCRI, and the Active Surveyor Newsletter.
Hi, Larry and Nancy. How you doing?
We're doing great.
Great.
Good. My name's Justin. I'm a genetic counselor, and I want to spend a little bit of time talking to you today about genetics and how that applies to you. It's a bit of a sci-fi topic, and I want to explain what this means clinically nowadays.
Well, it's very nice to meet you. Nancy and I are on this journey together. I hope you appreciate that. We're trying to do everything as a family here, since whether or not I have cancer or not, or any genetic problems, impacts all of us. Nancy has done a great deal of research on my behalf and has helped tremendously down this path.
So it's really nice to meet you. And we've written down a few questions, but we're really very unfamiliar with genetics. So I wonder if you'd allow us to record this session today.
Yeah, absolutely.
Okay, great.
I was diagnosed with prostate cancer, Gleason 6, recently. And I think I even read that some people don't even consider Gleason 6 to even be prostate cancer, but in any event, our urologist recommended that we see a genetic counselor to see if there's other testing that might be done to help us better decide about our active surveillance situation. It seems that there are other criteria that we might look at that you can probably help us with to better solidify that discussion, because right now we are on a path of active surveillance. And again, Nancy's done lots of research, but this is a fairly complex and confusing issue that we found to be difficult to sort out. So we're looking forward to hearing from you.
Yeah, no,
So,
very good.
So Larry's 70, and his dad
I wasn't going to say that.
died. He died from prostate. His dad died from prostate cancer at 74. So naturally, we've wondered for some time if he has inherited a risk of prostate cancer from his dad. And we're also concerned about our children, so that they might learn if they could possibly have some sort of inherited risk factor. And the urologist mentioned something about BRCA1 and BRCA2 genes being important. And are there others as well? Anyway, so we have a lot to learn.
Yeah, no, I think that these are all great concerns, questions, and when we go down this journey of cancer, we're opening ourselves up to a lot of terms and thought processes that we never anticipated we'd need to know about, and so I can understand how there can be questions and wanting to get as much information that we can to make the best decisions that we can. Let me start off with talking just a little bit about genetics and how genetics applies to cancer in general, prostate cancer specifically, and when it comes to perhaps decision making, or how it can apply to active surveillance, and then how it can apply to other family members. So let's start with the genetics piece right off the bat. So all people are made up when there are eggs and a sperm that fertilizes the egg. That's how we get the genetic information that makes a person a person. We get half of our genes from mom's egg, we get the other half of our genes from dad's sperm. And we have 20,000 genes that make a human a human. Our genes are almost always working just fine for healthy adults. And sometimes there are mistakes or mutations that we have inherited from mom or from dad that can cause medical problems. Now, if we're focusing on the world of cancer genetics, there are some genes that protect us from cancer, and we want these genes to be working perfect. Some people are born with a mistake or a mutation in one copy of those genes, maybe the copy they inherited from mom's egg, maybe the copy they inherited from dad's sperm. And if people do have these inherited gene mutations, means that these genes that protect from cancer can't do their job as well, and people are predisposed to getting certain cancers. All cancer is genetic. All cancer occurs when a healthy cell accumulates mistakes or mutations, either through exposure to the environment. Think about a skin cell. When we get a sunburn where it's radiation that's hitting our skin, it's causing DNA damage, and our body removes that, and our skin comes off sometimes through a burn. Sometimes these mutations can happen more subtly, and our cells accumulate mutations that then get repaired by repair mechanisms that we have in our cells. But the process is imperfect. It's 99.999% accurate, but that 0.001% is enough sometimes for these healthy cells to accumulate mutations throughout someone's lifetime. If we get the right mutations in the right genes, it can lead that cell to go down this trajectory of becoming cancerous. And really, a cancer cell is just a healthy cell that's started to go rogue, divide uncontrollably, take up resources around it. And this process of mutations that can accumulate within just that cluster of cells that eventually turn into a tumor. And so there's an important difference in that. When we say that all cancer is genetic, it doesn't mean that we're all born with genetic predispositions. It means that the cancer itself has lots of gene mutations. And that information can actually be really insightful for doctors. There's some doctors who want to take a sample of your prostate tissue or cancer tissue in order to learn more about the cancer to better treat it. That's a type of genetic testing. It's called somatic testing or tissue testing, where we just look at the tissue itself to see if there's a mutation. Whenever we do testing of the tumor itself, we're just looking at the DNA present in that tumor or that cancer. If we were to take a sample of the tissue, the healthy tissue right next to it, the DNA inside of both these tissues would be very different. The cancer DNA would have lots of different mutations in it that made that tissue cancerous. And the healthy tissue next to it would probably have very few mutations, expectedly no mutations. And that's the healthy tissue. But there are some people who were born with a gene mutation that they inherited from mom or from dad that may have helped expedite this process. And these people have what's called a hereditary cancer syndrome or predisposition to certain cancers. And so that's what another type of genetic testing can identify, and that's called germline genetic testing. Germ comes from the fancy scientific word for meaning a cell like an egg or a sperm, where we inherit these genes from. And if we do germline testing, whether we use a saliva sample or a blood sample, doesn't matter. All we're looking at is some type of tissue sample to see, are there any mutations in these cells? And are these the cells that we inherited from mom or from dad? Any questions about that?
Well, I was wondering why the sample of that's sent for somatic, why can't that sample also be used for genetic?
Yeah, it's a good question. And so if we do send a sample for somatic testing, we will see that germline mutation there. We're going to see all this other noise of all these other mutations.
Okay.
And so what we could do is we could sample the tissue itself, and we say, okay, well, this is what mutations are present in the cancerous tissue. And then we say, let's also do a germline, and we'll spit into a tube or take a blood sample, and we can compare. If the germline's negative and there's lots of mutations in the somatic, we say, okay, well, these are the mutations that we're working with for this cancer. But some people have lots of mutations in the somatic. That's always going to be the case. And they also have a mutation that's present in all of their saliva cells or blood cells. And they say, oh yeah, there's a germline mutation and there's all these mutations in the tissue. So you can have both, or you can have one or the other.
Okay, gotcha.
Well, so in my situation, where I'm a Gleason 6, I mean, I understand the BRCA1, BRCA2, if it can impact my son or daughter, or impact my treatment, it might need to be more aggressive, I guess. But are there other testing that you think of or that one might take to better inform a person doing active surveillance?
Yeah,
I
and
mean,
so
that's the thing I'm not sure about. I don't even know if I really have cancer by some people's definition, and yet we're talking about genetic counseling.
yeah. And so, genetic counselors typically live in the world where we focus on the germline stuff, where it's focusing on the genes that we have inherited from mom or from dad. And so that's usually that blood test or that saliva test that can give us insight to, hey, was I genetically predisposed to get this cancer that I have now? And you mentioned the genes BRCA1 and BRCA2. Those are two very important genes in anybody's prostate cancer story. Most people don't have mutations in these genes. Most people's BRCA1 genes and BRCA2 genes are working just fine. The impact of these gene mutations that we've inherited on something like active surveillance, for example, has been somewhat studied, but maybe not well studied enough. It's difficult for us to make clinical decisions based on someone's status of BRCA1 or BRCA2. And there's another gene out there, it's called ATM. And the reason why I'm picking on these three genes is because there was a study that was done, I'm going to say in 2019, that analyzed 1,200 men who were on active surveillance and looked at their genes, BRCA1, BRCA2, ATM. And they said, okay, listen, for the men who have these mutations, how likely are they to reclassify on active surveillance? And what that means is if they are Gleason 6, what's the chance of them moving up to Gleason 7, given that they have these G mutations? And one thing that was interesting in that study is they found that men with BRCA2 mutations were more likely to reclassify. In fact, they found that people with all three of these mutations were more likely to reclassify, but the bulk of that was men with BRCA2 mutations. So for some people, they may say, hey, well, if I have a BRCA2 mutation and I go on active surveillance and this study says I'm more likely to reclassify, should that be a thing that I should be talking to my doctor about? And maybe we should be thinking more about other strategies. Or if I do choose active surveillance, maybe my active surveillance protocol is a little bit different from guys who don't have the BRCA2 gene mutation. So this is another piece of information that we can use to inform our care. There's lots of genes that can be tested for that are associated with prostate cancer that we know of now. We picked on those three, but there's plenty of genes. And these genes aren't usually just prostate cancer genes. They're usually genes that increase risk for a bunch of different cancers. Sometimes it is just prostate cancer, but sometimes it's prostate cancer and colon cancer, or prostate cancer and breast cancer in both men and women. Sometimes it's increases risk for, the genes can increase risk for ovarian cancer. And so this could be something that has implications not only for an individual and their current risk of prostate or their current prostate cancer management, but also potentially other cancers that that man may be at risk for, as well as if it is a germline mutation and he inherited his genes from his parents, well, there's a chance he could pass that gene on to his kids and they could be at elevated risk for cancers as well.
What kind of test do you recommend him taking?
Yeah, so I think that doing genetic testing to understand your germline status is important. It's an important piece to understanding the kind of puzzle of what we should be doing going forward. Insurance companies may be able to cover some aspects of genetic testing. Sometimes genetic testing can be paid for out of pocket with different companies that are out there. There are also clinical trials that are available that would offer genetic testing as being involved in the clinical trial. One such one is the PROMISE registry, where any man with prostate cancer is eligible for participation in that trial and gets germline genetic testing as part of that. If insurance doesn't cover it, there's other options to pay out of pocket or to be involved in clinical trials. And then getting this genetic information is something that healthcare providers can sometimes use to help inform medical decisions.
We have done some YouTube work, okay?
Okay.
So I'm sure nobody does that, but
it's great.
yeah, or not, maybe, I don't know. But Nancy, did you look at a couple of things that you were wondering about, different types of tests?
Well, the Oncotype DX, but that's somatic, right? And the Decipher again. So, Meg, do you think that Larry should do those as well, or just go straight to the genetic PROMISE?
Yeah, it's a great question, and I think that those are decisions that you make with your oncologist, and they can help facilitate those types of tests for you. Again, if it's another piece of information that could be useful in your management, if your Oncotype DX comes back and shows that your prostate cancer looks genetically like it's not as aggressive, that might be useful information. But that moves into that territory of treatment decision makings that oncologists like to use, and typically those healthcare providers are the ones who would help facilitate that type of somatic or tissue testing.
Okay, so as far as accessing the genetic testing, where's the best way to access, for example, the PROMISE study?
Yeah, so the PROMISE study.
Should I just Google it?
Yeah, exactly. So Prostate Cancer PROMISE is the website for that. But if you just Googled prostate PROMISE study, it'll pop right up there.
Okay.
And enrolling in this registry, and basically a registry is just a collection of individuals who have something in common, and in this case, it's men who have prostate cancer. As part of that registration process, you sign up for genetic testing, and they send a saliva kit to your home. You spit into a tube, mail that saliva kit back off. That facilitates the genetic testing, and then when we get the results back, you have the opportunity to talk with the genetic counselor about your results.
So that would be you, right? I mean, we would be possibly getting this done to you, coming back to you to go over our results of the testing.
Exactly. And so
that's whatever testing you suggest that we should probably do, to help in our decision making.
Yeah,
right?
yeah. And so a lot of these tests, are focused on certain types of cancer. So it could be a cancer gene panel or just a regular hereditary gene panel. With the PROMISE study, it's a panel of looking at cancer-related genes. There's 29 of them, and they cover all the known prostate cancer-related genes. And whenever anybody does a test like this, there's different types of results that we can get back. And so sometimes we talk about what's called anticipatory counseling, so that we know what people are signing up for when they do a genetic test like this. And when someone does do a test like this, we can get different types of results, and some of the language that's used in the results can be a little bit confusing. I have been using the word mutations or mistakes to describe changes in genes that can cause problems, but really what they're called are variants in genes. And there's multiple different types of variants. Most variants are benign, which means that they're not problematic. And those variants are typically not reported. But if we do find variants that are problematic, and we call those pathogenic variants, those are gene mutations or changes that are medically significant, and that could change someone's care. We know that a pathogenic variant could be problematic and cause the gene not to work as well, and cause a downstream condition.
So what percentage of patients that you test or that are tested, do you know what percentage are found to have a significant marker? Yeah,
so it really varies based on the type of prostate cancer that an individual has. It also varies based on something like family history. So Larry, you described having a father who has prostate cancer, who had prostate cancer in his 70s. And with that family history, having two individuals who were diagnosed with prostate cancer after the age of 60, the risk of having a gene mutation actually isn't super high. And that's a gene mutation in one of these known genes. If someone was diagnosed with a metastatic prostate cancer, a prostate cancer that spread to other parts of the body, there's about a 12% chance that they have a gene mutation that may have predisposed them to that type of cancer. So there's different factors that we take into play that can help us estimate someone's risk of having a gene mutation or a pathogenic variant.
I'm also curious about what other aspects of my family history that might be important that we look at.
When it comes to family history, genetic counselors like to get as much information as we can, not only about prostate cancer and ages of diagnosis, but also about other connected cancers, like if there's a family history of breast cancer or ovarian cancer, pancreatic cancer, colon cancer. This could maybe increase or decrease my assessment about what the chances are of finding a germline mutation. And so if the family history is just prostate cancer, and age of onset is not what we consider to be early, such as over the age of 60. The chances of us finding a known gene mutation that's kind of on our radar today is not very high, maybe about 5% chance. If I can kind of extrapolate a little bit on some of the data that's out there. But if there was, for example, a family history of ovarian cancer, which is a lot more rare, regardless of the age at which someone was diagnosed, then the probability might be a little bit higher.
Well, in terms of my family history and even extended family history, the only cancer that I know that of my family was my dad's prostate cancer. So otherwise, although being 70 at the time that other people might have had cancer, I mean, it might not have been diagnosed. You know, I mean, it just wasn't. In fact, my dad's diagnosis and whether or not he had metastatic disease and that sort of thing was not well understood either. So I think that's one of the reasons why we're also curious about the genetic studying too. But I think you've answered many of our questions. We may have some more, but so right now we should do the testing that you recommended and the promise.
Promise.
And promise. And then get back together, or how long does it take? Or
It can take maybe around 4 weeks, sometimes up to 6 weeks to get a result back from a genetic test. That's usually from the time that a sample is sent out. It can vary from lab to lab. And then when results get back, there'll either be a prompt for you to speak with a genetic counselor. Sometimes it's something that's encouraged, and sometimes it's something that if the result is positive and shows something that's meaningful, there might be more steps to take to communicate those results.
if it comes back, I mean, will my urologist get a copy of this, or will you or someone else be talking to my urologist to let him know, or is that something that we're supposed to do? Or?
It typically depends upon who is ordering the testing. Sometimes if a urologist is ordering the testing, it'll go back to them. If you are ordering the testing yourself, then it'll go back to you. And it's always something that you can share with whichever healthcare provider you want. And yeah, so a urologist and oncologist always be really a useful people to have access to this information.
All right. Well, thank you very much.
Thank you so much.
No problem.
We appreciate all the information. It's excellent. Thank you.
Thanks to all our participants in today's webinar. Thanks also to Alex and Peter Schultz of PCRI, who have made the resources of PCRI available to the Active Surveillance Coalition in helping to produce and edit these webinars. Please stay tuned to further webinars in the AS 101 series. Thank you.
Today's video is with Justin Lawrence of Sunnybrook Hospital in Toronto, Canada. Justin is a certified genetic counselor through the American Board of Genetic Counseling. He practices clinically out of the Sunnybrook Odette Cancer Center in their Cancer Genetics and High Risk program. He's also the lead of Male Oncology Research Education, MORE, a registry for men and hereditary cancer, as well as a consultant on the well-advertised PROMISE study. His current academic interests are in the hereditary cancer with a focus on male breast cancer and prostate cancer genetics. The video also features Larry and Nancy White, a couple from New Mexico, who have been through this themselves and are our model team. Our programs deliberately avoid PowerPoint slides usually shown in webinars in order to replicate as much as possible what a real counseling visit is like. The AS Coalition includes the Active Surveillance Patients International, ASPI, the AS Virtual Support Group from ANCAN, the PCSC Nationwide AS Virtual Support Group from Canada, Prostate Cancer Research Institute, and the Active Surveiller newsletter. Thanks go out to Alex and Peter Schultz of PCRI, who have made the resources of PCRI available to the AS Coalition in helping to produce and edit these webinars. Thank you.
Hi, Larry. Hi, Nancy. Good to see you again.
Hi, good to see you.
Good to see you, I hope.
Yeah. So I can see we got the results of the genetic testing back, and you've had a chance to review those.
We have, and it looks like I'm negative for the different parameters that we were looking for.
That's right. Yeah. So we ended up, you ended up getting tested for 29 different genes, and whenever they do genetic testing, if you think of a gene being like a book, they read through these 29 books line by line, page by page. They were looking for spelling mistakes or mutations. Before, we talked about how we classify those mutations as either pathogenic variants or benign variants. There's these other type of variants called uncertain variants. And a negative result means that they did not find any of the problematic variants, the pathogenic variants. And they also didn't identify any of these uncertain variants. Instead, they probably found a whole bunch of benign or likely benign variants, and those just aren't reported. And so your result comes back negative, which is a good thing. We didn't find any mutations that are problematic in your genes.
Well, so we feel a little bit better with that news. So.
Yeah, and so I mean the limitation. Yeah. And so it's a good result. This is kind of what we're hoping for. I call these results boring. And genetically, we always want to be boring. With respect to your family history, you mentioned that you have a father with prostate cancer. And so this test can only look at the known genes that are associated with prostate cancer, but there are lots of unknown genes or little small markers within genes that we know can be increasing risk for prostate cancer that we didn't test you for because they're not on our radar at this time. And family history is an important guide that we can use to help predict what someone's risk may be. And so any man who has a family history, a first-degree relative, that means that they have a brother or a father with prostate cancer, we know that there's a bit of an elevated risk. And as a result, when looking at, for example, your son, he has a father and a grandfather with prostate cancer. So despite the fact that you don't have any known gene mutations, your son's family history is enough for us to want to be a little bit more careful about his prostate screening because he still may be at elevated risk based on these other genes that we don't know about yet.
And our daughter?
And your daughter, well, the genes that I think about that connect breast cancer or ovarian cancer to prostate cancer, we've ruled out. So we didn't find any mistakes or mutations in the genes like BRCA1 or BRCA2, or the genes ATM and CHEK2, which are known genes that to be connected to prostate cancer and breast cancer. And so your family history of prostate cancer doesn't mean that there's any elevated risks for your daughter. I'm not overly concerned about her or don't think that she needs to change any of her management if there's no other family history of cancer.
Great.
Well, how about our son? I mean, this, I guess, is controversy as to whether or not or when you get a PSA test.
Yeah.
And so with my dad having prostate cancer, I have prostate cancer. Does that mean that my son should probably have, or should he have his PSA tested earlier, or certainly pay attention to it? He's what, 35?
Yeah.
40, something. I don't even remember.
He's about 35.
About 35.
Yeah, and so it's a really great question. You're right. There is some controversy regarding PSA testing, and I guess that's a discussion for a whole other kind of a talk could be given on that. But these become conversations between healthcare providers and patients. Ultimately, family history is definitely a clue for us to want to kind of be having these discussions about prostate cancer screening. Sometimes there are, some organizations that may say, hey, let's start having these conversations and maybe considering if there is a family history screening in someone's 40s, maybe 45. But these are usually recommended as conversations with healthcare providers, and there's no kind of a hard, fast rule in terms of what we should be doing in terms of prostate screening if there is a family history, but definitely something that should be discussed.
Okay. He's going to kill me that I got his birth date and my daughter's birth date. He's not going to be happy with this. So I hope he doesn't watch this video.
Listen, let's not put pressure for parents to know the birth dates of all their kids. It's okay. And in my field, guesstimations are all that I ever need. And if we're off by a year or 5, I'm happy.
Good.
Your secret's safe with me. The other thing I wanted to ask really quickly, in your family history, is there any Ashkenazi Jewish ancestry?
Not to my knowledge.
So the reason why we bring that up is that we know that individuals who are of Ashkenazi Jewish ancestry might have a higher chance of having a BRCA1 or BRCA2 gene mutation. There's actually a high risk for a couple of other gene mutations as well. But these are things that are also kind of on our radar, and sometimes nice to be able to rule out in kind of populations where their risks are a little bit higher than people who aren't, for example, of Ashkenazi Jewish ancestry.
Well, I do have Native American heritage. So is there any issue around Native Americans with prostate cancer or not?
Yeah, it's a really good question. In fact, there's a lack of information on lots of different populations that aren't as well represented within the research community. So First Nations, for example, individuals of African American ancestry, really what makes our ability to give risk percentages, to be able to talk about treatment and management options, is to study as diverse a population as possible. And if we're only focusing on individuals who are white, then our data is representative for people who are white. And organizations, registries, clinical trials are always asking and encouraging people from the African American community, First Nations communities to be involved as possible, so that we can better represent these populations in our data. And so, to answer your question, there's a bit of a lack of data, so I don't know if I can answer that accurately.
Okay. No.
Okay, great. So you did your genetic testing. We didn't find any known mutations associated with prostate cancer. There could still be some other gene mutations that we don't know about that could have attributed or contributed to your risk for getting prostate cancer. And as a result, other family members may have some of those minor gene mutations as well. So family history is an important thing to consider when it comes to risk perception for other family members. But of our known gene mutations like BRCA1, BRCA2, ATM, genes like the genes that are associated with Lynch syndrome, which is connected to colon cancer, we didn't find any mistakes or mutations that are problematic there. And that's a really great result.
Excellent.
That's good.
That's good. So at this point, should Larry get genetic testing again later, or just say this is good? And I mean, should we wait and see if more than 29 are tested for in the future, or what should we do?
Yeah.
What should Larry do?
Yeah, it's a great question. And so there's 20,000 genes that make people people. We're just taking a small snapshot of these genes now. And so you're right, these gene panels can expand, and they do expand. So it's an important thing to think about. Remember the year that you had your testing done. People who had genetic testing done for cancer-related genes 10 years ago, that gene panel is completely different than it is now. And so I would always put the year that you had testing in context, because there might be opportunities to redo testing and look for more genes in the future. I will say this, that the genes that you've had tested, these 29 genes, they don't need to be retested. We got the information. Okay. Those books have been read. Those genes have been analyzed. Your genes aren't going to change, but what could change is our interpretation of those results. And so it's always good to know that the results themselves won't change, but our interpretation of the results could change as new studies come out and as we learn more.
Okay, well, that's good to know, because on active surveillance, I mean, I'm going to probably have more MRIs and probably biopsy in the future. So nice to know that I'm not going to need to repeat what we've already done necessarily. Is that correct?
Yep, no need to repeat the same test, but if they come out with a fancier gene panel with more genes in the future, you probably will have to provide another saliva sample or give a new blood sample and get those extra genes tested as well.
And that's the same, that's true. Even let's say in 2-3 years, hopefully not, but that I end up with a 3+4 or 4+4 Gleason, something like that. I hope that doesn't happen, but the genetic studies or whatever, I guess, again, we don't need to look at the same genes necessarily, but
so
other studies, I don't know.
Also in the other studies, I mean, this is a study, PROMISE, and there are other genetic tests available. And I was wondering, do they all test for different genes, or are they pretty much the same?
Yeah.
No.
Yeah. You got it. It's the yes and the yes. That's all. Yeah. So there's lots of different panels that are out there. We call them panels. It's a gene panel. It's the way of saying that there's a test just has multiple genes, and we call that a panel of genes. There are some panels that have 80 genes on them, some that have 16, some that may have even more. And so it's kind of what the genetic test is looking for. If we're looking for every type of genetic predisposition to cancer under the sun, even the rare stuff that we don't really know too much about, sometimes those bigger panels will have everything under it. But when we're looking at other panels, they might just be looking at genes that if there's a mutation, we know what to do with these genes, and if they're mutated, we have a protocol and a plan. And so some are kind of just selected for, you know, what we know what to do with in 2022. And some people may say, well, why would I test for a gene if no one can tell me what the management is if I have a mutation in that gene? And so, yeah, there's lots of variety, and more isn't always better. There are just sometimes there's just a core number of genes that you want to have tested, and sometimes an oncologist may be able to give you that direction about what they are looking for, that may help them with making medical decisions. And as long as your panel covers those, then you may be okay.
Okay, well, thank you very much. We really appreciate your information and your help.
Yeah, no, thank you for the great questions. It's been a pleasure talking with you both.
Thank you for attending this genetic counseling video segment of AS 101. Look for additional segments of AS 101 that will be available shortly.
Well, thank you all for, particularly Nancy, Larry, and Justin. What a great program with great information. You know, it's interesting, Larry, that your father died at 74 from prostate cancer, as my father did at 76. And back then, it was all genes. There was no epigenetics above the gene. In other words, we can change. Now we understand that we can change the expression of the genes. But back when my father died in 1996, that idea of epigenetics was just surfacing. And so when I saw that he died, obviously it created greater anxiety when I was diagnosed in 2005. So we can see how things evolve, and our programs are designed, we hope, to offer you a sense of peace. I call it peaceful vigilance. So, you know, after a few years with prostate cancer, I finally got to a point of peaceful vigilance where I just live with it and I don't think about it. I don't worry about it. And you too can get there as well. It's not not that much of a stretch. And that's, we're hoping that these programs will help you to get to a point of peaceful vigilance. And by the way, along that line, I wanted to mention too about the PROTECT study. And the PROTECT study established the longevity with your longevity is going to be the same if you choose active surveillance, if you're low, intermediate risk prostate cancer. Your longevity is going to be the same if you choose active surveillance, if you choose radical prostatectomy, if you choose radiation, it's going to be the same. So obviously one is going to lean towards active surveillance if you're going to live the same length of time, no matter what course you follow. Now, we're very fortunate here to have with us today Michael Glody. He's on our advisory board, and he's a professor emeritus of medical oncology and at the former Robert Rifkin Chair and the former Robert Rifkin Chair for Prostate Cancer Research at the University of Colorado Cancer Center in Aurora, California. And Mike, listen, I was looking at your bio today. Your credentials are way too long and too impressive. We're gonna have people's eyes glaze over if I tell them all of your kudos. So I think I'm just gonna skip all of that, and I know you won't mind. But I really, we are grateful for your volunteering your time here to help men navigate active surveillance and hopefully reducing their anxiety. I saw too in your bio your commitment to compassionate treatment of your patients, and for active surveillance patient in this coalition. This is very much part of what we want to do with the men that are following us. I really want to honor your commitment to patients navigating active surveillance and express our gratitude for your being here today. You could be out skiing with your grandchildren in Colorado right now, but you're here with us to help men navigate prostate cancer, and that speaks to your compassion. And I'm sure that all here are very grateful for the fact that you've chosen to do that. So thank you. And with that, why don't you share some thoughts?
I'm happy to, Mark. I hope everybody can hear me, and it's an honor to be here. A few disclaimers. I'm not a urologist. I'm a medical oncologist. I spent most of my career doing research in prostate cancer and taking care of prostate cancer patients who are more advanced. I'm also a prostate cancer survivor. I had a Gleason 3+4 about 10 years ago. And we've learned a lot since then. Perhaps I would have chosen active surveillance, but the details of my case were that the cancer was pretty close to the capsule. And at that time, my own reading of the literature was having a pattern 4 is like being a little bit pregnant. So I was not inclined to do any active surveillance. I just had treatment. And I've had both surgery and radiation. My PSA started going up a little bit after my prostatectomy. So I've lived the life and taken care of a lot of patients. Also, from the family history point of view, both of my parents died of cancer. So my father was 65 when he died of leukemia, and my mother had breast cancer, and then eventually, before she died, a colon cancer. So my family genetics are not good, and I've had a 75, I guess, gene panel looked at, and there's nothing there. But when we say nothing there, it's probably not true. So as the video showed, there are lots of genes that probably have each one a small effect, and my family probably carries some of those mutations that we don't know enough about. So my two sons, because I had prostate cancer, I've advised them to get their PSAs early. They're both in their 40s, and their PSAs are less than 1. And my very crude criteria for talking to people about PSAs, which can be a lecture itself, PSA should be less than 1 when you're 40, less than 2 when you're 50, less than 3 when you're 60, less than 4 when you're 70. It's kind of a very crude way of looking at it. But I think in the case of the men on this call who have prostate cancer, if you have sons who are, they have a higher risk, regardless of the genetics, because you have prostate cancer. So I'd recommend earlier surveillance. They can talk to their family physician or talk to a urologist or talk to an expert, doesn't matter, but I would certainly advocate, earlier PSA testing and digital rectal exams in family members of people with first-degree relatives, father or brother who have prostate cancer. So I think I'll share my screen and just show one thing that Mark alluded to, which was the PROTECT study. If I can find it here, maybe it's this one. If I screw this up, no, it's not that one actually. Here we go. Well, while I'm here though, this is the active surveillance guidelines from experts. So this is the NCCN guidelines, and actually the experts don't necessarily recommend doing genetic screening. So it really comes down to if you've had prostate cancer and you have a positive family history for any other kind of cancer, considering either joining one of those studies or tests to do that. And while I'm here, I guess I'll show this slide just because, This is the one that's the PROTECT study. So I think we lose sight of the issue of how nobody dies from prostate cancer. So these are specific survival curves, and you can see out here to 17 years, 95% of people, regardless of active monitoring, radiotherapy, or prostatectomy, are doing really well. Metastasis-free survival falls off a little bit, maybe 5% or something like that for the patients who chose active surveillance. So that kind of brings up the issue of how do we find these needles in the haystack? Not everybody on active surveillance is totally going to live out 20 years with nothing happening. There's a few patients who will develop metastases, but they're not going to, here's the picture, they're not going to die from it. So it's a real challenge, I think, in the field. And this sort of shows the curve of men on active monitoring of some sort in the PROTECT study. And you can see by 5 years, maybe 40% of people sort of fall off the wagon, and they either have the appearance of Gleason 4 or they become too nervous and they decide for active treatment. And by the time you get to 10 years, maybe it's up to half. But a lot of people are still going out here without needing any therapy, and therefore they don't have the side effects. And again, going back to the forest and not the trees, you're not going to die of prostate cancer. It's not 100% true, but it's really likely. So I think we lose sight of that when we're trying to talk about all these details. Most of us with any kind of prostate cancer, including myself, I suspect, are not going to die of prostate cancer. So that's the big picture. I just wanted to share that, and then I think I'm happy to go to questions and answer.
Terrific, thank you. Well, one thing is somebody expressed an interest in a little bit more on distinguishing genomics and genetics. Can you help with that a little bit more?
Yeah, so just to try and reiterate, and I thought that the video did a good job of it, maybe the simplest way to think about it is genetics, in a sense, are what you inherited. And you may or may not have inherited some genes that are relevant, like he talked about BRCA1 and 2 and ATM and so forth. Genomics are the looking at the tissue, the cancerous tissue itself, and seeing what kind of mutations are in that cancer. And not everybody who develops cancer has the same set of mutations. So a prostate cancer that looks the same under the microscope might have different mutations that are leading to that cancer. And in the end, when the cancers become more aggressive or whatever, it may change the type of therapy we choose. For example, if you have a BRCA mutation, BRCA2 in particular, there are ways to use drugs that take advantage of that for treating people with more advanced disease, with metastatic disease. So you can do the genomics on the tumor itself, or you can, these days you can look at circulating tumor DNA. So in our patients who have, most patients with prostate cancer that metastasizes, which is my area of specialty, as a medical oncologist, I take care of people with more advanced disease. As I'm sure everybody on this call knows, they get treated with hormones. And the hormone therapy usually puts people into some sort of a remission for anywhere from 2 to 10 years, and sometimes longer. But in that situation, we're starting to work out when the PSA starts going up and there's more spots appearing on scans and so forth, are there mutations that have been picked up by the cancer that we can see in the circulating tumor DNA, and would that guide our therapy in some way or another? So that's the genomic side of things. It's the cancer genes that we're looking at. The genetic side of things are what you inherited. Hope that's helpful.
Perfect. Well, let me ask one other question that was in the chat box. Somebody here said that the PROMISE study was not available to active surveillance patients, although I know a couple that didn't get tested with that. Do you have any comments on that, Mike? Do you know anything about that?
I don't know the criteria for the PROMISE study for who gets in and who doesn't. the best resource for all clinical trials really is clinicaltrials.gov. And you could go to clinicaltrials.gov and enter surveillance. You could enter prostate cancer and surveillance, and you would have access to all the trials really worldwide, but certainly in the United States, that you might participate in. And you can scroll through the criteria. They all have the list of entrance criteria. And so, you know, if you're interested in a clinical trial, and we absolutely support that, that's how we move the field forward and know more about things. But go to clinicaltrials.gov, enter the words prostate cancer and surveillance, and you will see all the available clinical trials that are underway that you could potentially participate in.
Thank you for that. I just saw a question in the chat box from Jeff, and then we need to see who's raising their hand. Jeff, do you want to ask your question about lifestyle? You still there?
Yes. Good morning. Thank you, doctor. And again, thank you for joining our organization. We really appreciate your expertise and your kindness and your the charity of your time. Thank you again. Lifestyle, we kick it around, exercise. I'm trying to get ready for a run. I feel like a mule that just got kicked, but you know, I'm 70 this year. I'm going to give it a trial, run in a local race, a charity. And then secondly, eating. Would you care, and I know there's a mixture of opinions on this, and I'm not selling pills or anything, but could you give us kind of a frank discussion about exercise and diet?
Sure. First of all, pills. Come to my website and I'll sell you pills. No, I'm kidding, but you can certainly find politicians and others who are selling pills. Let's start with exercise. I became in the last decade or so more and more convinced that we don't spend enough time hyping exercise. So I literally spent 5 or 10 minutes in every patient visit, and these are mostly, again, patients who have advanced disease. They've had treatment. They've probably got relapse and have a rising PSA. They're on hormone therapy. And when you take away testosterone from men, it's critically important that they exercise, because you start losing muscle mass. But actually, once you're 50 years old, sorry to say, you start losing muscle mass anyway. And we've had, in some of the different, forums that I've been a part of, we've had exercise gurus who are motivational speakers and stuff. And at the end of those talks, you feel like, oh my gosh, I want to go find some weights and start lifting weights. But I have a kind of a routine for myself, as well as every patient, that I strongly recommend. And there are thousands of, well, hundreds at least, of articles looking at different forms of exercise, how much you need, and so forth. But here's my take. I think that you should exercise a minimum of 3 times a week, and it should include cardio as well as resistance training. So what I do myself is I get on an elliptical, actually, 3 times a week. And I do 25 minutes of that training, and I try to get my heart rate up to 80% of predicted max. So the predicted max is 225 minus your age. So I'm 75 years old. So my predicted max is 150. So I try to get up to 130 and get my heart rate up there in an interval training at least 3 times during my 25-minute exercise routine. Then I get off the stupid machine and go downstairs and grab some weights. And the way I recommend, and I'm not an exercise physiologist, so this is amateur hour, but based on what I've read and listened to some of these lectures, you exercise each large muscle group until it fails. So that means, let's say you can, in my case right now, I'm at, I think, 25 pounds for curls. So I do 2 sets of 12, but on the second set, I fail. My muscle won't get me to 12. If I can get to 12, then I go up on the weights. So I go up so that I always fail in the second set of 12, and it could be 15 reps or 12 reps. It doesn't matter too much, I don't think. And I do that on the thigh machines, and I do that on the everything else. And then I throw in some balance tests because we're all old guys, and doing some balance exercises and some stretching exercises are really important. But the total workout for me is 55 minutes, and it's 3 times a week. And I can't emphasize enough how important that is. Regardless of what's happening to your cancer, you're going to live a better life, and you're going to experience less loss of muscle, which is called sarcopenia, if you get your butt off your couch and stop looking at your iPad and go do that 3 times a week. And it makes the rest of things go well. I can, like you said, ski with my grandkids without as much things. And I've got friends who don't do it, and they, when we go skiing together, they can't, they get tired faster. So regardless of what you like to do outdoors, you're gonna have a lot better time, and you're gonna live, regardless how long you live, you're gonna live a better life if you really get serious about exercising. And I myself didn't get serious about it until about 10 years ago when I started hearing these things. If you look at the cancer survival issues, that makes more difference than anything you can do with diet. The exercises and any kind of vitamins you can take, or anything else. So you can do pomegranate juice, and you can do, the Cancer Society vegetables and nuts. All of that's good, but I think exercise outweighs all of them in terms of the effect. I don't know if that answers the question, Jeff, but that's where I'm at with it.
Thank you very much. And I'll be the first member of your hiking club when you open it.
Okay.
Well, thank you. So I see a hand up. Jay Newman, do you have a question you wanted to ask, Jay?
Yes, I do. Thank you for all of the helpful advice. I've had cancer in 2020 in the prostate, Gleason 4+3. Went through hormone, Lupron, and 45 treatments of external beam radiation. This year, my PSA went up. I had a PSMA PET scan. It showed 2 places in the pelvis, the lymph nodes. So I'm on Degarelix and Xtandi, ADT, and I'm scheduled for radiation, external beam radiation, 30 to 35 treatments. And I was wondering, which genetic testing would you recommend? And by the way, I think your exercise idea is a fabulous one. I've been doing some Tai Chi for balance, but the other exercises that you mentioned sound very good.
Yeah, so we're not going to try and give everybody specific recommendations, but it sounds like you're on the right track with what you're doing. The recommendations are for people with high-risk disease, meaning Gleason 4+3 or higher, 4+4 or any pattern 5 are sort of high-risk patients from a Gleason standpoint, and their PSA criteria too, like greater than 20. All of those people are recommended to have genetic testing, and that means the kind of panel that was talked about. And the main reason for that, well, there are 2 reasons. One is there may be a gene that shows up in one of the panels that would change the therapy for a person like you. And then secondly, the family issue. So patients with metastatic disease are all eligible for, insurance usually covers genetic testing. So you should talk to your physician about genetic testing. That's clearly in the guidelines, and if it hasn't been done. And then the genomic testing in somebody like you, again, that's the genes that are in the tumor itself, could be done with just a blood test called circulating tumor DNA. And you can talk to your doc about that test too. And I would recommend doing that. I would get both genomic and genetic testing.
Right.
Okay.
I'd really encourage you to, your situation is a little bit beyond our expertise, but we have a close working relationship with ANCAN, which is a great organization. And so they have the Advanced Cancer Support Group. So if you haven't checked them out, I'd really encourage you to check them out. By the way, you don't have to raise your hand if you want to just unmute yourself. You can chime in if anybody has other questions. Are we good? I don't hear anybody saying anything.
I just
There's
had
one
a,
that just,
Go ahead. Who was that?
my name is
Yeah.
Paul. Yeah, I just
Paul,
had a question
go-
about
go ahead,
understanding the importance of genomic versus genetic. So if you have low, if people have low risk cancer and the genetics are low risk or there's no very little concern. And, the biopsy slide is a couple of years ago, don't even know where the material is anymore. How important is it to get genomic testing or to get another biopsy just to get the genomic testing?
for somebody who has a Gleason 3+3 and is on active surveillance, I don't think, I mean, the video did a pretty good job. I don't think that until someone comes up with, another way of looking at what you're really talking about there is there a way to pick out those, whatever it is, 5% of people who are on active surveillance who eventually develop metastases and leave the other 95% of people alone? And we're not there yet. There's a cool set of tests being developed that are barely available, and they were in the ASCO meeting this year, but let me just explain it this way. When a pathologist looks at the microscope slide that you talked about, in point of fact, they're looking at all the genes and all the proteins that are expressed by those genes that cause it to be cancer. And they're looking at visually changes in those cells that make it a Gleason 3 versus a Gleason 4 versus a Gleason 5 and so forth. So in reality, all that information is kind of there. It may be different sets of genes and protein expression that causes some cells to look wilder than others, but all that information is there. And so the challenge to the field really is, what are those other genes? And how, each one might have a 3% impact on how that cancer behaves. And right now, you have the 50 genes or the 75 genes or the 150 genes that we know about, but obviously there are other genes that each one contributes a small amount. So there was a really cool paper presented at ASCO, and there's a company developing those called Altera. It's not ready for prime time, and I don't recommend anybody does it. It's just something to keep your eye on. But using artificial intelligence to look at the kind of whole slide and say, is there information there that AI can pick out that would sort out the patients with, let's say, Gleason 6, like most of the people on this call, and find out those 5% of people that are actually likely to progress. And if so, maybe that would change their, would change the active surveillance protocol. Maybe you get an MRI more often or a biopsy more often, et cetera. So keep an eye on that. I think the AI world, which is hot right now, if you will, may well impact what we do as much as sending off, let's say they go from a 75 gene panel to 125. Is it worth what you're asking, going back and getting another biopsy or getting the slides sent off to a different company? I don't think so, but if once you've, and again, most of the people who have 3+3 don't fall into a category where there's recommendations for genetic or genomic testing anyway.
Thank you. Yeah. So just one last clarifying question. So I have Gleason 6, but I had a friend who had Gleason 6, had even less cores than I did, lower PSA than I did, but he took a deciphered test and it created a sense of panic in him to go immediately get a prostatectomy. So then I'm wondering, well, my numbers are worse than his, and he went into panic. And I don't feel like I'm worried right now, but he all of a sudden got very worried. So just trying to understand how to process that a little bit.
Yeah, that's a tricky business, right? Because we have these genomic tests, and Decipher's one of them, and Prolaris and so forth, that you can send your tissue off, but there are no prospective data to say that if you act on, let's say, a high GPS score with Decipher or whatever, that it was the right thing to do. Those tests start off with you look at, let's say you have the ability to look at 100 genes in the laboratory, and you say, could these 100 genes predict what's going to happen? And so you go to a big place like Sloan Kettering or MD Anderson and say, give me 1,000 patients that progress from Gleason 3 to Gleason 4. And I'm going to see if my 100 genes can predict who those patients were. And if your 100 genes can do that with some kind of accuracy, and let's say at 70%, then you say, well, is this true? And now I'm going to go to, UCSF and take 1,000 patients that I don't know what happened to and accurately predict what's going to happen to them, because these are patients that have been followed for 20 years and so forth. That's how you develop these panels. And there really aren't panels for Gleason 3+3 patients that have been prospectively looked at. The Decipher test has probably the most number of papers and the longest history so far, but it's currently being looked at in protocols of the type I told you about. Go to clinicaltrials.gov, and there will be clinical trials going on to see if you can prospectively make good decisions based on genetics or genomics, and that's sort of the state of the art. So your friend may or may not have made a good decision based on a Decipher test pushing him over the edge. And you could just, if you ask Lori Klotz, who's an expert in active surveillance and so forth, about Gleason 3+3 patients and should they get genetic testing and all that, it's difficult. He's looked at the most patients of anyone in the world, I think, and he's, will tell you the higher the number of cores that were positive, the higher the chance that eventually you end up with some pattern 4 somewhere. But it's a tricky business, and even the issue of how often to get screened, how often do you get a repeat PSA, how often do you get MRIs and all that. Those are all kind of clinical. What's the preference of the urologist, and what are the data that support doing one thing versus another.
Thank you.
I wanted to add to that worry doesn't get us where we want to be. Worry serves no master. And I know from myself, when I was diagnosed back in 2005, I spent 2 or 3 years worrying, do I have an aggressive cancer? And after a while, I figured out that wasn't helping me at all. And so that's why I've really tried to emphasize as much as I can the message of peaceful vigilance, and that you can all get to a place of peaceful vigilance. Yeah, it's good to have the data. That's good. But as soon as you get to worry, shift your thinking, move on to another place, because the worry is not going to serve you at all.
Keep this in mind.
Yeah, the PROTECT study, exactly. Yeah.
Yeah, you're just people with Gleason 3+3 are going to do very well. And that brings us back to, if you're going to die of a heart attack or colon cancer or something else, exercise is probably more important as to where you are on that line. Because the overall survival here at 20 years curve would go down like that. And these are all people dying of other things, right? Even people with high risk disease. I was a part of a study and looking at prostate cancer patients with high risk after prostatectomy, and more patients died of other cancer than died of prostate cancer. So those were people with Gleason, 4+4 or worse, or they had positive lymph nodes, et cetera. And still, more people died of other cancers. So prostate cancer is not a toothless tiger, but it's something that you've got to have a real perspective on and work on other things in your life.
Well said. I see Bernard has his hand up. Bernard, do you want to unmute yourself?
Yes, I am. Can you hear me?
Yes, perfectly.
Yes, thank you for calling on me. Yes, I was diagnosed December 1st with just a Gleason 3+3. I'm on active surveillance, and my urologist recommended a repeat MRI and biopsy in a year from now. And I'm wondering, and also PSA testing, I believe on 6-month intervals. And I'm wondering, with regards to, and by the way, my initial biopsy showed 1 of 12 samples with some cancerous cells. Another one that was undiagnosed, but it looked suspicious. So very early stage. And I'm wondering, obviously, an MRI is very important to monitor. And by the way, the first MRI that was done showed no tumor, and it looked very, very benign. So I was even wondering, do I have prostate cancer? My urologist said, well, yes, you do, but it's very early stage. So I'm wondering, when I get the continued work, should I have the MRI first? And if it still shows very little, if any, progression, do I really need another biopsy?
Great questions. First of all, I mean, it's up to you and your urologist, and what you're describing sounds very, typical and important. There is at least one study out there that I'm aware of that looked at, could you, if your MRI doesn't show anything progression-wise, do you have to still get other biopsies? And there's at least one study that suggests you can at least increase the interval between biopsies using an MRI, and that it's a safe approach. But that's the bleeding edge of what we know, and I think what your urologist has described is excellent. Normally, yes, you'd get the MRI before another biopsy, so that if there was something showing up on the MRI, you could direct a few more biopsies towards that particular area. But it sounds like you're getting the right advice to me.
Thank you. One other question on the PROTECT study you mentioned. Can you talk a little bit more about that? Is that something that would be appropriate to enroll in?
It's over. So, I mean, the PROTECT study was looking at, patients who were diagnosed, I think, in the late 1990s. And so we have this 15 to 20-year follow-up on all those patients. And it was a randomized trial of, there were a large number of patients who had elevated PSAs or whatever, and were offered randomization to surgery, radiation therapy, or active surveillance. And then, they were followed along to see what happened to them. And that's the PROTECT study. And this is one of the most mature studies with large numbers of patients that resulted in those graphs that I showed you.
Gotcha. Thank you.
Let me make
But if there, again,
Mhm.
I'll just put in a pitch for research. There are ongoing studies of various sorts looking at things like genomics and genetics, and how often to do biopsies and all those things. And again, go to clinicaltrials.gov and enter prostate and surveillance, or prostate cancer and surveillance, and you will probably, I haven't done that, I probably should have before this seminar, but you may well find trials that you're eligible for. And gosh, I really encourage everybody to participate in trials when they can. That's how we get data like the PROTECT study, so that we can learn about things.
Indeed. I wanted to make a comment on PSA. We all know that PSA is affected by a whole variety of things: sex, riding a bike, a number of other things. I just learned that COVID too can affect PSA, increase the PSA number. So you need to be very aware of that, and maybe be retested if you have had COVID. And a point too that I want to make is that we almost shouldn't even be talking about PSA. We should just be speaking of PSA density. And I've made this point a whole bunch of times in these webinars, but I don't think it's commonly used by even the urological profession. And again, with PSA density, you put the PSA number over the size of your prostate, and you come out with a number. And as long as that number is below 0.15, you're probably fine. You probably don't need any further treatment, or need not be anxious about your progress. So I encourage you all to ask your urologist about what your density is, not just your PSA. What's your density? Unmute yourself if you have other questions. I don't see any hands up.
Yeah, because Steve Hamaker, Dr. Globe, why is density not more commonly spoken about it in forums such as this?
You know, I'm not a urologist, so I see urologists who use it all the time. I mean, the issues, PSA, on the one hand, is an incredible marker, right? It's it's why everybody's here on this forum. If it wasn't for PSA, you probably wouldn't be here. And on the other hand, the different ways of, you know, you can look at the different forms of PSA. You can look at PSA velocity. PSA is a kallikrein enzyme, and there's you know, a lot of different tests to say who should you biopsy besides just the PSA. Are there predictive things? And PSA density is one of them, but it's imperfect. There's no perfect test to either say who to biopsy or who's likely to progress and so forth. So, you know, Mark's right, a PSA density gives one additional piece of information, and some people rely on it more than others. But I think we are all addicted to PSA, and both patients and doctors, and we all know that a PSA that's going up fast is not good, and a PSA that's stable or not going up is where we want to be. The reason the density comes into play is because if you have an enlarged prostate gland that doesn't have any cancer in it, the more prostate cells there are, the more PSA leaks into the bloodstream. And the reason the cancer can be diagnosed is because when the cancer cells leak more per cancer cell, if you will. And that's why the PSA is useful as a screening tool.
Thank you. Any further questions?
Yeah. Hi, this is Jim. Can you hear me okay?
Yeah, go ahead, Jim.
Yeah, I was diagnosed as a 3+3 at a PSA of 4 in 18, and I had another biopsy done in 21, and now I'm a 3+4 and a PSA of 6. But in the past 9 months or so, my PSA has gone to 15. What do you think? Is it time for me to seriously consider treatment, or can I stay under active surveillance?
I think we're supposed to not give specific recommendations.
And that's that is true, but the density, I mean, your prostate could be, there's prostates that a 15 would be okay because you have a really enlarged prostate. So I'd check out my density to start with, for sure.
If your PSA has jumped a lot though, and you've been watching, you know, it's not just density, it's also velocity. So somebody whose PSA is creeping along and going 4, 4.2, 4.5, 5.1, and then suddenly jumps to 10 in a 1 year interval, that's of high concern to me, at least. So I would have a serious discussion with your urologist about what to do.
Thank you.
Okay. Thank you.
Any other questions? All right. Well, Mike, thank you so much. That was really helpful. Your answers and all the questions were great too. We appreciate all of you being here. And Mike, we're going to let you go skiing now if you want. I wanted
going back to babysitting, actually.
Okay. I wanted to also remind, some of you came in late. I wanted to remind you all of Throne's Cavemen support group. I had mentioned earlier about that we're creating a standing support group with the same members of the support group. So you build the relationship, you build a brotherhood, and you help each other on this journey. And so Throne put his email address in the chat box. So if you want to join that group, please email Throne, and I'm sure he'd welcome you in that group. And Active Surveillance Patients International, well, all the groups here probably are looking for volunteers, but we're desperate for volunteers. So if anybody has some talents or interest in this subject, interest in helping other men navigate this journey, please get in touch with us, and we're happy to try to fit you in some way.